In my training, I did neurology initially. And when I was in neurology, I got very interested in neuropathology. And so I would end up doing, in pathology, we would do autopsies for the coroner's office and things like that. And along the way, you get to see the brain in a different way. In development, about 3 weeks into after conception, the brain and nervous system starts forming as a tube, and then on one side of the tube, these bubbles or blisters start forming, and then they become the brain, and then the spinal cord is left behind, and then from the brain come the eyes. But around those ventricles, which is the fluid-filled space, there's all these primitive cells. And first go up these glial cells. They're scaffolding, and they go out to the surface of the brain. And then afterwards, these neurons then go up and they form the cortex all around. And then they start these interconnections and so on and so forth. And then the brain develops, and then these myelin sheaths so that the nerves can conduct more quickly. And then by the time of birth, the skull isn't formed yet, and the brain is growing. And, if you look at a child, the head and the eyes are a little bit larger, and then we kind of grow into our adult form. So, it's a very complicated system, and there's a lot of trafficking of other cells, like immune cells, that go through the brain. About 15% of our cardiac output just goes right to the brain, straight off the top, because we need oxygen and glucose, because if there's not enough of it, then, we'll pass out. The brain is just that delicate and beautiful of a system. And we imprint in our brain, and we develop our identities and our personalities and our knowledge base. And all these wonderful things happen. So around the ventricles remain these stem cells, So we have a certain set of genetics, and we have a certain set of, bone marrow going through, and white cells, and cells that traffic through the brain. And we have the spinal fluid coursing through and kind of cleansing in between the cells. And we have this electrochemical circuits just dazzling, emotional circuitry, knowledge circuitry, movement circuitry, feeling circuitry, everything. So at some point in time, some combination of, who knows, an exposure risk, a genetic predisposition, a set of genes making it more likely in some combination that a tumor cell is created, some auto-destruct mechanism that goes awry, some set of circumstances goes wrong, and then 2 or 3 per 100,000 people, for example, have a glioblastoma happen. And then that glioblastoma, which we used to call glioblastoma multiforme until just a few years ago, because there's no other type of glioblastoma, it was shortened. But the multiforme is still an important descriptor, because when we try to recreate this tumor in in an animal model, a lot of times it's curable, but why do we have such difficulty with this in the human condition? There was a recent paper that validated what we've all kind of known, is in this subventricular zone, there have been stem cells, and the stem cells kind of are called by attractants that are elaborated by the tumor, and then they go over there and then they modify and make that tumor different and stronger, and more resistant, and many times more aggressive. And probably it's the same thing from stem cells that traffic through that, stem cells that come from the bone marrow and your immune system, and it makes it very difficult to tackle, although it does give other targets, and methods of trying to, figure out how to contain it. I think a lot about, I talked earlier about, making lists of like the differential diagnosis, what's most likely, the most dangerous to least dangerous list, and then what can you cure, what can you treat, in all of medicine, really, the things that we can treat are far outnumber the things that we can cure. So, for example, if somebody says they have diabetes, I mean, we could do a good job of making that a chronic condition and expanding a person's life expectancy. But, I don't have something where I could say, well, if you take this today, then you won't have diabetes anymore. Same thing with high blood pressure, hypercholesterolemia. You can modify some things, but ultimately, if there's a familial genetic hypercholesterolemia, it's not curable. You have to take everyday anti-cholesterol medicines. But you can cure some cancers, and you can cure infections. The rest are palliative. If a person hurts, well, you should, maybe by surgery you can cure some things, but from a medical perspective. So that being said, it's not a bad, in my estimate, idea to coexist with something that one can't cure, and it may be the better strategy to do that rather than to have a curative intent and then destroy the brain that is so vital. You can the battleground that the war is being waged on is super critical, and so we have to make concessions and try to have a long-term plan with the minimal damage to the brain. With that being said, many new treatment strategies are focusing on immune-based therapies. So with our colleagues at the Brain Tumor Treatment Collaborative out of the NIH, and through the consortium, there's a very interesting study, for example, with the heat shock protein and pembrolizumab, which looks to leverage an immune reaction against tumor cells and tries to leverage particular targets that are important in fighting those cancers. That's an exciting trial, for example. Another one is one that we share with University of Florida. Another vaccine study looking at a different target, one of a virus called CMV, cytomegalovirus, and a particular protein that can be exhibited disproportionately, and trying to give a lesser toxic therapy to patients, not injuring the surrounding brain. Standard of care therapies that are worn, like the Optune device, which is in electromagnetic fields that are alternating electrical fields that break up cells without injuring normal brain cells, and wearing it, and behavioral modification to wear this thing as long as possible. These clinical trials have out 5 years where people had a 5% 5-year survivorship went to 13%. And now there are some data that say, well, for people who can wear this device for over 90% of the time, which is a tall order, there could be upwards of 25 or 30% of people who can survive to the 5-year mark. Things that we would never really even entertain saying 10 years ago are happening. We have other clinical trials that, all sorts of clinical trials and targets that we're always looking at, and they're invariably targeting many of those aspects that I talked about, whether they're stem cells or whether they're going after immune system cells or trying to destroy dividing cells, all of these look for ways to individually target and destroy tumor cells while preserving brain. And those are just some of the common strategies that we use.